Welcome back to the Deep Dive, everyone. To our listener, the learner, we know you are always looking for those aha moments and really dense information. And today we have a fascinating one for you.
We really do. It's one of those topics that, completely changes how you look at a routine medical visit.
Exactly. Because usually, when you think about getting a medical scan, you expect this laser-focused, absolute precision, right? You go into the clinic with a persistent cough, your doctor orders a chest CT scan to look at your lungs, and that is exactly what the radiologist looks at, the lungs.
Right. The whole medical diagnostic system is basically built around that kind of specificity. A physician asks a very specific question, and the radiologist looks at the image to provide that specific answer.
But what if, while they're zoomed in on your lungs, an entirely different story is playing out in the background of that very same image, like a hidden treasure map sitting right there on the screen?
Yeah, a map pointing directly to your future cardiovascular health.
Which is wild. And according to a massive new 2025 review in the journal Radiology, cardiothoracic imaging, that is exactly what is happening millions of times a year. The review is called Coronary Artery Calcium Scoring on Dedicated Cardiac CT and Non-Cardiac CT Scans.
And the supplementary visual data they provided with it is just staggering, honestly.
It really is. So our mission today is to explore how a routine scan for something else entirely like a lung check might actually hold the secret to preventing your next heart attack, and how the medical system is rushing to unlock this opportunistic data. So, okay, let's unpack this.
Let's do it, because we are witnessing a fundamental shift in how we view medical imaging right now. Instead of just looking at what we ask the scan to show us, the field is realizing, hey, we need to look at everything the image is actively trying to tell us.
Right, the collateral information.
Exactly. And the specific target the authors are focused on here is called coronary artery calcium, or play check.
Okay, so before we talk about finding this hidden data, we need to understand the mechanics of what the medical community is actually looking for, right? The review describes CAC as a marker of subclinical coronary atherosclerosis.
Right. Which in plain English just means we are talking about heart disease that is actively developing before it ever causes a single symptom.
Sneaky heart disease.
Very sneaky. It begins on a microscopic level, It starts as these tiny inflammatory microcalcifications deep inside the intimal layers of your coronary arteries.
And the intimal layer is like the innermost lining of the artery wall.
Yes, exactly, the innermost layer. And over time, as the disease progresses, these tiny microcalcifications clump together and they grow into much larger calcific lesions.
So if we use the classic analogy of a house's plumbing, it is like checking for rust. But we aren't just talking about rust building up on the inside surface of the pipe where the water flows, right?
No, it's more insidious than that. We are talking about calcification embedding itself deep within the actual metal of the pipe itself. Yeah, causing the wall to swell and bulge inward. And that eventually leads to a rupture, which is the actual mechanism behind a heart attack.
That inner wall swelling is such a perfect, if slightly terrifying, way to visualize it. And because this calcium buildup tracks so tightly with your risk of a cardiovascular event, measuring it has become this major guideline-recommended tool.
Right. And the gold standard for doing this is a dedicated, electrocardiographically gated, non-contrast cardiac CT.
Okay, wait, we have to break down that term, because electrocardiographically gated sounds incredibly intense.
It sounds like science fiction, I know. But the process is actually incredibly efficient. Gated just means the scanner is physically hooked up to an ECG.
Oh, so the camera is perfectly synchronized to the rhythm of your beating heart.
Exactly. It takes the picture in the literal split second between beats when the heart is perfectly still.
Which eliminates any motion blur.
Right. And because it doesn't require any contrast dye, it's fast and cheap. It usually costs, between $50 and $150 out of pocket.
That's surprisingly affordable for a medical scan.
It really is. It takes less than 2 minutes in the machine and exposes you to a very low dose of radiation, about 1 millisievert.
Which is roughly equivalent to the background radiation you just naturally absorbed from the environment over 6 months anyway, right?
Yeah, exactly. It's a very low-risk procedure. And when they get that crisp, still image, the radiologist calculates your score using what's called the Agatston method.
Right, invented in 1990 by Arthur Agatston and Warren Janowitz. And the math here is brilliant. They look for calcium lesions that are greater than 1 square millimeter. Right.
Correct. And then they measure the density of that lesion using Hounsfield units.
Okay, for context for the listener, Hounsfield units are just the standard scale for radiodensity. Like water is 0 and solid bone is up in the hundreds or thousands.
Exactly. And the threshold for coronary calcium is 130 Hounsfield units. So the radiologist takes the area of the calcium and multiplies it by a density factor.
And that density factor operates on a scale of 1 to 4, right?
Yeah. A density between 130 and 199 gets a weight of 1, but incredibly dense calcium over 400 gets a weight of 4.
And you sum all those up across all the lesions in the heart, and you get this continuous numeric scale known as your Agatston score.
Which is a profoundly powerful prognostic tool. The resulting numbers fall into these distinct risk categories. A score of exactly 0 means absent calcium,
Which the sources note comes with a warranty period of about 5 to 10 years, where your risk of a heart event is just incredibly low.
Right, it's the best score you can get. Then a score of 1 to 99 is mild, 100 to 299 is moderate, and over 300 is severe.
And didn't they recently add an extensive category too?
They did, yeah. For scores over 1,000, if you are walking around with a score over 1,000, your risk is equivalent to someone who has already been diagnosed with established cardiovascular disease.
Okay, I had to push back on the math here, though. Yeah, because something seems really off. If we are measuring the total volume of calcium buildup and multiplying it by a density factor of 1 to 4, shouldn't denser, thicker calcium be a much bigger red flag? I mean, going back to our pipe analogy, a thicker, denser layer of rust inside the wall of the pipe seems infinitely worse than a thin one. Why is a high-density multiplier bad if... Wait, I might have this backwards.
I see what you're saying. You're hitting on what the medical community calls the density paradox. It completely flips our intuition on its head.
Okay, explain that because I'm confused.
So a larger total area of plaque spread across the heart definitely means a higher risk. But when you isolate the density of an individual lesion, higher density actually indicates plaque stability.
Wait, really? So harder plaque is somehow safer plaque? Why would the body prefer it to be hard?
Because less dense plaque is essentially a volatile, lipid-rich core filled with active inflammatory cells. It's covered by a very thin, fragile cap.
Oh, yuck. Like a blister.
Exactly like a blister waiting to pop. That is the kind of plaque most likely to rupture, spill into the bloodstream, and cause a sudden, catastrophic blockage.
I see. And the highly dense plaque?
Highly dense calcified plaque is basically bone. The body recognized the inflammation, attacked it, and walled it off, turning it into a hard, stable scar. And a scar is highly unlikely to rupture.
Okay, wow. The body is essentially fossilizing the threat to neutralize it?
Yeah.
That makes perfect sense. So while you ideally want 0 calcium, if you do have it, you want it to be as dense and stable as possible.
Exactly. But the total score and the density are only part of the equation here. According to the data, knowing exactly where that fossilized rust is located dictates your actual threat level.
Location, location, location.
Always. Which brings us to the CAC-DRS, the Coronary Artery Calcium Data and Reporting System. It's a standardized framework that merges your total Agatston score, or visual score, with the specific number of epicardial arteries involved.
And the epicardial arteries are the major blood vessels sitting right on the surface of your heart, supplying it with blood, right?
Right. And the system labels the involved arteries from N0 up to N4. But the review makes it very clear that not all arteries are created equal. The high-stakes anatomy here centers specifically on the left main coronary artery.
Why that one specifically?
Because the left main coronary artery is the critical pathway for blood traveling to the left side of the heart, and the left side does the heavy lifting of pumping blood to the rest of your entire body.
Ah, so it's the main highway.
Exactly.
Yeah.
If you have a total FAC score greater than 1,000 and more than 25% of that burden is concentrated in the left main artery, your risk profile is identical to a very high-risk patient who has already suffered multiple heart attacks.
Even if you are currently sitting there with 0 symptoms and feeling perfectly healthy.
Even then, it's a silent alarm going off in the background.
That is terrifying.
Yeah.
But this location data ties into a really important distinction the authors make between your absolute score and your percentile. Let's put this in perspective for you, the listener. Say you are 35 years old, you get a scan, and your absolute Agatston score is a 15.
Okay, 15.
On paper, 15 is technically in the mild category of 1 to 99. But if we look at percentiles, a 15 for someone that young must mean your internal clock is ticking way faster than your peers, right? You are developing rust decades early.
That is exactly right. Absolute scores predict your 10-year risk of an event. Because you're only 35, your 10-year risk of a heart attack is still statistically low, simply because you are young.
Right.
But percentiles predict your lifetime risk based on your specific age, sex, and race. A score of 15 might be totally average for a 65-year-old. But for a 35-year-old, a score of 15 might place you in the 90th percentile.
Meaning 90% of people your age have cleaner arteries than you do.
Exactly. Your lifetime risk is massive compared to your peers. Reporting those percentiles is the only way to trigger early, aggressive preventative therapy when there's still plenty of runway left to change the trajectory of the disease.
Okay, so if percentiles and precise locations are this critical, the obvious question is how we actually get this data into the hands of patients. Which brings us to the shocking truth highlighted in the source material.
The blind spot.
Yes, the 19 million scan blind spot. You might think everyone should be rushing out to get this dedicated cardiac scan. But millions of people are already getting their calcium scanned every single year, and the medical system is just, well, leaving the data sitting on the table.
It's true. Annually in the United States, there are about 600,000 dedicated ECG-gated CAC scans performed. But there are over 19 million non-cardiac chest CT scans performed every single year.
19 million. These are the routine scans for lung cancer screening, or when you go to the ER with breathing issues.
Right. And because your heart sits right there in the middle of your chest cavity, it gets fully captured on those lung scans too. This is what the medical field calls incidental CAC.
Right, incidental. It's calcium spotted in the background of a scan meant for something else. And the studies prove that this incidental background calcium has the exact same prognostic value for predicting downstream cardiovascular disease as the dedicated scans.
And it costs $0 extra. It exposes you to 0 extra radiation.
Exactly. And the guidelines from the Society of Cardiovascular Computed Tomography and the American College of Radiology have explicitly stated for years that radiologists should be evaluating and reporting this incidental calcium.
But in actual practice, it is vastly underreported.
The numbers out of Johns Hopkins Hospital illustrate this perfectly. They took a random sample of patients undergoing routine chest CTs. They found that 50% of those patients had visually detectable coronary artery calcium on their scans.
Half of them.
Half. But it was only actually reported in the radiologist's final written impression 10% of the time. I mean, how does a medical professional look at an image, see a massive risk factor for the #1 killer in the world, and just not write it down?
Well, there are genuine technical pitfalls we have to acknowledge first. These non-cardiac scans are not synchronized to your electrocardiogram. The camera isn't timed to the still moment between heartbeats.
Right, so the heart is actively beating and moving while the camera is taking the picture?
Yes, which causes motion artifacts. It blurs the image, which can sometimes make a small amount of calcium look larger than it is, artificially inflating the score.
Okay, that makes sense.
And beyond the blurring, non-gated scans often use thicker slices of imaging. Think of it like taking fewer, wider pictures of the chest rather than hundreds of microscopic paper-thin slices.
So it's lower resolution, essentially.
Exactly. Because the slice is thicker, a tiny microcalcification gets its density averaged out with the surrounding soft tissue in that specific slice. That averaging effect can drop the density below the 130 Hounsfield unit threshold.
So it just disappears from the math.
Right. As a result, the review notes that about 2% of people who have mild calcium on a dedicated scan will falsely show up as having 0 calcium on these thicker, non-gated lung scans.
Okay, so the tool isn't perfect. But missing 2% of mild cases doesn't explain why 90% of all incidental calcium goes completely unreported.
No, it doesn't.
It's like having a security camera set up to watch a bird feeder in your front yard.
Right.
All right? And in the background of the footage, an arsonist is literally walking up to your house with a gas can.
That's a great way to put it.
But the security guard reviewing the tape completely ignores the arsonist, doesn't even log it in the report, because their boss explicitly told them to only count the birds. The threat is right there on the tape.
Well, the security guard in this scenario is suffering from clinical inertia. Radiologists are working under immense pressure, reading hundreds of complex scans a day. They are trained to answer the specific clinical question asked by the referring physician.
Does this patient have pneumonia?
Exactly. If the doctor asked about pneumonia, the radiologist looks for pneumonia. If their electronic reporting template doesn't explicitly force them to stop, look at the coronary arteries, and grade the calcium, human psychology dictates they simply will move on to the next scan.
Plus, there's the fear of overstepping boundaries, right? A lung radiologist might feel hesitant to formally document a cardiology diagnosis.
Absolutely.
So how do we fix this inertia? How do we force the medical system to look at the background of the security footage?
The authors point to a combination of behavioral nudges and artificial intelligence. The Johns Hopkins intervention is basically a masterclass in behavioral design.
Oh yeah, they didn't just hold a seminar and tell their radiologists to do better, which never works.
Never. Instead, they fundamentally changed the electronic medical record reporting templates to make the right choice, the path of least resistance.
They made it a simple button click using the CAC-DRS system.
Mhm.
So a radiologist doing a lung scan doesn't need to do the exact Agatston math. They can just visually estimate the calcium, which is called V-scoring.
Right. They click V2 for moderate calcium and click N4 to note it's visible in all 4 vessels.
And then the software automatically generates the text. Moderate diffuse coronary artery calcium in all vessels, and drops it right into the final report.
By simply changing that software template, Hopkins and the University of Miami saw their reporting rates jump from that abysmal 10% up to 96%.
Which is incredible. You engineer the system so that recording the data is easier than ignoring it.
Exactly. But the true paradigm shift here relies on artificial intelligence, specifically deep learning models.
Oh, this is where it gets really futuristic.
It does. We now have AI algorithms capable of running in the background of the hospital servers, constantly analyzing every single non-cardiac chest CT that gets taken.
Because the AI doesn't get tired.
Yeah.
It doesn't suffer from clinical inertia or worry about stepping on a cardiologist's toes. It just crunches the pixels.
Exactly. And these deep learning models have greater than 90% sensitivity and specificity for detecting CAC compared to the gold standard scans. The AI can actually generate continuous exact Agatston scores automatically from a blurry, non-gated lung scan.
Which solves the thick slice and motion blur problems.
Yes, it compensates for them beautifully. But once the algorithm finds the calcium and calculates the score, the healthcare system still has to ensure the patient's primary care doctor actually acts on it.
Right. Getting the data to the doctor. This is where best practice advisories, or BPAs, enter the workflow. These are automated pop-ups in the electronic medical record.
Right. If the AI detects a V1 or V2 score, mild to moderate calcium, the EMR system physically interrupts the doctor's workflow with a pop-up.
Prompting them to consider prescribing a moderate intensity statin to lower the patient's cholesterol.
Yep. And if it detects a V3 score severe calcium over 300, the system prompts them to order high-intensity statins plus low-dose aspirin.
Because at that severe level of calcification, the benefits of preventing an imminent heart attack vastly outweigh the slight bleeding risks associated with daily aspirin.
Exactly. And the clinical applications triggered by these automated scores are expanding far beyond just cholesterol management. Knowing a patient's hidden CAC burden helps personalize their entire preventative strategy.
I saw the review cited the SPRINT trial for this.
Yes. The SPRINT trial showed that if a patient has a calcium score between 200 and 300, it justifies targeting a much more stringent blood pressure goal of 120/80, rather than the standard targets.
And there's even observational data regarding GLP-1 receptor agonists, right? The massive new class of weight loss drugs like semaglutide.
That's a huge development. If a patient has a CAC score over 300, a body mass index over 27, and no history of diabetes, the calcium score provides the concrete medical justification to prescribe the therapy to prevent a future cardiovascular event.
Wow, so the AI is just teeing up the exact right treatment. And the proof that this kind of automated detection and notification works is found in the Notify-1 trial.
Oh, the Notify-1 trial is incredible.
It's groundbreaking. They took patients who had prior routine chest CTs, no clinical history of heart disease, and who are not currently taking any statins. And they ran a deep learning algorithm over the old scans to quantify the hidden calcium that had been ignored.
Right, retroactively checking the tape.
Exactly. They then randomized the patients into 2 groups. One group's doctors got delayed notification, basically business as usual where the data just sat in the file.
And for the other group, the doctors and the patients themselves were immediately notified by the system about the presence of the hidden calcium.
The gap in clinical outcomes is astounding. Within 6 months, 78% of the people in the immediate notification group were prescribed statins.
78%.
Yeah. And in the control group, who were left in the dark about the data sitting in their own medical files, only 12% received a prescription.
That is a massive life-saving gap, bridged simply by turning on the lights, running an algorithm, and pointing at the data that was already there.
Which brings up a highly actionable takeaway for you, the listener. If you or a family member ever go in for a chest CT, whether it's for a bad cough, an ammonia check, lung cancer screening, you now know to explicitly ask your doctor, What did my coronary arteries look like? Did the radiologist note any incidental calcium?
You have to force them to look at the bird feeder and the arsonist.
Yes, you paid for the scan, you absorbed the radiation, and you deserve the full prognostic value of the data captured inside your chest cavity.
Absolutely.
But, if this AI is already scanning the background of these images for heart rust, it begs the question, what else is it seeing? You can't just be blind to everything else in the chest cavity.
No, definitely not blind.
Mm.
The algorithms are currently being trained to hunt for all sorts of extracoronary findings.
Like what?
For instance, aortic valve calcium. If the AI spots calcium building up on the aortic valve, it is a remarkably strong predictor of future aortic stenosis risk.
Oh, wow.
They are also training AI to spot mitral annular calcium, which is linked to entirely different mechanisms of non-cardiovascular mortality.
It's like it's mapping everything.
It is. They're developing deep learning models that can automatically measure the exact sizes of your heart chambers, quantify the amount of epicardial fat you have surrounding the heart, and even measure your bone mineral density to predict your future risk of osteoporosis.
All from that single routine scan you got just because you had a cough.
All from that one scan. And looking slightly further into the future, the traditional Agatston visual scoring we talked about earlier might be entirely replaced by what researchers call radiomic feature scores.
Radiomic feature scores.
Yeah. The AI won't just look at the raw density and area of the calcium, it will analyze the microscopic textural features of the plaque, patterns that the human eye cannot physically perceive.
So it creates a hyper-accurate risk profile based on the microscopic architecture of the disease itself.
Exactly. Though we do have to mention, there are significant hurdles to getting all this tech implemented universally.
Oh, sure. Like what?
Well, there's anatomic bias in AI training, for one. If the algorithm is only trained on scans from a specific demographic, it might miss things in other populations. There are massive data privacy concerns, obviously, when you have an AI scraping millions of patient files.
Right. And I imagine there's a huge socioeconomic divide here, too.
Definitely. There's a very real risk that rural or underfunded hospitals will lag years, maybe decades, behind massive academic centers in getting this tech. The gap in care could widen significantly before it closes.
That makes a lot of sense. But purely on the clinical side, with AI automatically reading the scans, finding the hidden calcium, analyzing microscopic textures, calculating the exact score, and then an EMR pop-up automatically telling the doctor which statin to prescribe. Does this essentially remove the human element of radiology entirely?
I don't think so. It's not about replacing the human element, it's about elevating it. AI frees the radiologist from the tedious manual task of counting pixels and measuring lesions with a digital ruler.
Right, the grunt work.
Exactly. By automating the abstraction of all this incidental background data, the radiologist can finally focus on synthesizing complex, multi-system information. They transition from being simple pixel counters to holistic diagnosticians.
That's a great way to reframe it. So to recap everything we've covered today, we started with the basics of coronary artery calcium, that rust swelling inside the walls of your pipes.
Right.
We explored how it acts as a highly accurate predictor of heart disease, governed by the counterintuitive nuances of density and the high-stakes reality of location in the left main artery.
And we learned that over 19 million routine CT scans happen every year containing this data, yet it has been largely ignored due to the clinical inertia of the medical system.
But now, AI, combined with behavioral nudges and standardized reporting templates, is turning this incidental finding into one of the most cost-effective opportunities to slow down the epidemic of cardiovascular disease.
We are finally extracting maximum clinical value from every single photon of radiation that passes through the body.
And that leaves us with a fascinating, broader philosophical question to mull over. As artificial intelligence gets better and better at scanning every single medical image for hundreds of secondary conditions in the background, are we entering a totally new era of opportunistic medicine?
It really feels like it.
I mean, think back to the beginning of our conversation about that laser-focused expectation of precision when you walk into a clinic. If one routine chest scan for a bad cough can simultaneously map your heart disease risk, your bone density, and your future stroke risk without anyone even asking it to, does the concept of a singular, targeted primary diagnosis even matter anymore?
The map has always been there. We are just finally learning how to read it.
We really are. Thanks for joining us on this deep dive, everyone. We will see you next time.